everyone, it's Paul. In this clip we're looking at the histology of epithelial tumours, so carcinomas. In this case it's a colonic carcinoma from a 52-year-old male, and we'll be looking at the primary tumour in the colon biopsy and metastasis in a lymph node. So this is the biopsy. You can see on the right hand side normal colonic epithelium, underlying connective tissue, a bit of a high power. You can see the goblet cell, morphology of the columnar cells. It's a simple columnar epithelium, all the nuclei arranged down along the basement membrane, and there's a bit of a lymphocyte infiltrate in between those glands. If we go back to low power, you can see that actually underlying that tissue is quite a different looking tissue, and that's the tumour. It's got not nearly the same level of organisation, so that nice normal tissue on the right and the left here. You can see it's lacking that glandular formation, although there are some areas that are a little tubular, but mostly it's nests of tumour cells invading into the connective tissue, and they're taking up most of the tissue mass. There's a few blood vessels there, and then you can see very large nuclei with quite prominent nucleoli in the centre of them. We can see variation in size and shape. This area here has sort of an attempt at making a gland. It's still got some glandular differentiation. So we have some vacuolation of the cytoplasm. We have the cells arranged down the base of the gland, a bit like trying to make a normal gland, but quite disrupted. Now, at the same time, lymph nodes were sampled, and a few of those are present on this section. Just looking at the first one, has quite normal lymph node architecture. You can see that round follicular structure. This is the medulla with the cords in it, and then just a normal lymphoid tissue. This is the second one. Again, you can see follicles of lymphoid tissue, but nothing abnormal in it. And there's a third node just over here, and you can see it's quite different. So we have normal lymphoid material on the outside, and then facing the architecture of the lymph node is this growth of tumour cells, which look almost exactly the same as the primary tumour. You can see a bit of glandular differentiation. So here they're lining up like gland cells around a lumen, and there is prominent nucleoli I'm pointing at, and cells arranged around like a basement membrane. Some areas also showing necrosis, and this area here is showing quite a bit of apoptotic debris, commonly seen in these rapidly proliferating tumours. That one there is quite a large nucleus. It's dark, it's hyperchromatic, and has a prominent nucleolus. And if you compare one nucleus to those around it, there's quite a bit of variation. So in summary, what we can see is disturbed architecture and loss of differentiation. So the cells not specialising as they should do and forming the tissue architecture they should. Nuclei themselves are quite dark staining, variable in size and shape, have quite prominent nucleoli. That's a feature of adenocarcinomas, glandular tumours. We saw mitoses, necrosis and apoptotic debris, and metastasis is a key feature of many malignancies, particularly carcinomas, and that was demonstrated